First of all, I'm happy to have you both here. I'm happy to introduce at the audience of this Congress, Professor Andrea Raballo and Professor Thomas Fuchs, and to ask them to talk about some of their scientific topics and to let you enter in the Congress Day in the way that you think it's the best way to keep in contact with your themes and with all the contexts we are going to face during our Congress Day. On behalf of all the members of GINCO, we really thank you for your presence. And if you want, feel free to introduce yourself to our audience. Thank you.
If I should start right away, I'm Thomas Fuchs, Professor for Philosophical Foundations of Psychiatry and Psychotherapy in Heidelberg, mainly working on the fields of phenomenology, embodiment, theory of neuroscience, and issues of embodied psychotherapy. I think that's enough.
Okay, thank you.
I'm Andrea Raballo, and I'm the Chair of Psychiatry at the University of Southern Switzerland, University of Lugano, and the Director of Research and Academic Training at the Cantonal Psychopsychiatric Organization. And I am the Chair of the European Psychiatric Association section of Prevention of Mental Disorders. And this basically somehow covers my main interests, which are related to phenomenological psychopathology and early detection of incipient mental disorder from the developmental years to youth and then sort of lifetime course.
Thank you. So we decided to start from a general but specific question. The question is, from a clinical and possibly phenomenological point of view, what do you think is important to underline in this historical moment about diagnosis and taking charge of a patient?
Well, that's a sort of epochal question, and it's not, I would say, something which is specific of this moment. I would rather say that it's a sort of constant innervation in history of psychiatry, because of course there has been a moment in which there was much more self-confidence in the diagnostic process and the kind of taxonomies we do use. But it's also true that there are cycles of revisions about the taxonomy and the epistemological foundation of classification. So if I have to sort of zoom in this period, I have the feeling that there is some sort of reenactment on a more sophisticated level of what was the debate at the very beginning of psychiatry as a science. So you have some sort of neurobiological orientation, which tended to incarnate some extremely reductionistic principle. You have more illuminated neurobiological research, and you have more psychotherapeutically or sociotherapeutically oriented articulations. But with respect to diagnosis, I mean, there is always a sort of immanent state of rediscussion. So you either have some sort of Talibanic belief in the current state of the art, which does not necessarily incarnate something more valid, but reflects the contingent view of the sort of mainstream community, and some more sophisticated attempt to look at it in a less behavioral way. So that's the current problem that I would say we are facing in the last 10 years. It's a pure subjective impression. But I also have the feeling it's a sort of historical reiteration of debates that have been there before, and that every time they restart anew, sometimes with a complete oblivion of the epistemological achievement that were made decades ago.
Yes, I would certainly agree with Andrea's diagnosis that psychiatry faces the same problems again and again in different guise from its beginnings. And there's a basic dualistic dichotomy or tendency in psychiatry which hampers the progress in the field again and again. But nevertheless, I would be inclined to emphasize a new direction of diagnosis and also corresponding treatment, which loses track of the tradition, and that's the lack of real in-depth psychopathology that is characteristic of current psychiatry. So diagnosis, as we all know, since the introduction of criteriological and manualized diagnostic systems, has considerably decreased the psychopathological expertise of young psychiatrists. And even in classical sites of psychopathology in Germany, you find hardly young psychiatrists who are really acquainted with the work of Carl Jaspers, for example. And the clinical expertise of diagnosing, let's say, schizophrenia in difference to histrionic disorder has declined deplorably in the last 10 or 2 decades. And that has also been deplored by major proponents of the original approach, as is well known. Even Nancy Andreasen has deplored and has lamented on the lack of expertise in young American psychiatrists. So I think what we really need is a new renaissance of not only classical, but in particular phenomenological psychopathology, for which the chances may not be that high, because on the other hand, we have a strong tendency to get rid of the classical psychopathology and nosology at all. So current biological psychiatry is on the verge of, well, getting rid of classical disease or illness units and changing our diagnostic approach according to the demands and needs of the biological paradigm, looking for arousal states, for attention disorders, for motivational disorders. So kind of disintegrating, fragmenting the classical units of disease and looking instead at single dysfunctions which can be further explored by genetic and biological psychiatry. So that is a real risk at the moment, and we should be very careful not to lose our tradition in this diagnostic sense.
I fully agree. And I mean, basically what we witness, and I fear I am more pessimistic than Thomas in this respect. It's not the last 10 years, it's probably about 3 or 4 decades.
Yeah,
this kind, I mean, you know, this kind of knowledge, which was the infrastructure of the way of thinking for clinicians, has been slowly degraded, simplified for the sake of speed, for the sake of this operationalistic simplification in general. And in many ways, you know, this has led to a dramatic loss in terms of critical thinking capacity from the viewpoint of the specialist, you know, that now has become extremely focused on certain manuals or certain checklists, but has lost the potential and the skill to capture gestalts, also to complex configuration, which are the essence for psychopathological diagnosis as well as for psychotherapeutic intervention and planning. So we now see this new terminology, precision psychiatry, personalized medicine. I mean, precision and personalization go hand by hand in psychiatry since its beginning, but they reside in the intersubjective capacity and in the subjective space that is created between the clinician and the patient. With the clinician, which has been depauperated of intellectual resources and impoverished in training, and without the passion for psychopathology, you end up having a meeting with a doctor which is an analphabet with respect to abnormal psychic phenomena and a suffering person. So it's sort of a catastrophic conclusion if you just look at the historical trend. And what is dramatic is that, you know, it's not only a question of rereading manuals, it's a question of having ostensive teaching, intersubjective sharing of knowledge with colleagues, which has been lost because most of the trainers, let's say the sort of senior clinicians who do not belong anymore to the generation that were trained in psychopathology, I mean, the current one are not even able to transmit this teaching because they don't have the basis. So it's an event which has happened on a global scale, first in Anglophone psychiatry, and then as a sort of echo in Europe as well. So now we need to undergo a sort of very self-aware renaissance that we deliberately try to instigate and instill in the new generation, because otherwise this is a corpus of knowledge that we're going to lose. And again, perhaps psychiatry is the last medical discipline which is still clinical. I mean, many of the other disciplines can completely operate without interhuman interaction, because in many cases, diagnosis can be defined on biochemical or histological or other parameters that go beyond subjectivity. But for psychiatry, subjectivity remains the central core domain that you have to address for diagnostic and therapeutical purposes.
Well, we should fight for another direction of psychiatry, which is going back to the roots of psychopathology, and then includes ecological and social psychiatric approaches that see the patient in his environment. And I think here the term of embodiment, looking at the embodied way that mental illness is felt and is lived and is manifested in one's behavior and expression, is particularly able to found an alternative to these reductionist approaches, because seeing the patient as an embodied being runs counter to the brain-focused idea of mental illness and enables an intercorporal and intersubjective approach to mental illness that sees the patient as embedded in his interactions, embedded in his family and social environment, and then looking at the real causes of mental disorders, which are very well known, actually. It's just that the official or mainstream psychiatry just doesn't want to see them. There are so many social causes and factors for mental illness which are well known. So the whole issue of exclusion, of migration, of losing one's familiarity with the environment are well-known major causes of mental illness, which are much higher in their impact than the genetic reasons, but they are just disregarded because they don't pay off in terms of research money.
Whereas phenomenology has always been sort of immanently anti-reductionistic. So, above all, it's an intellectual antidote to this kind of thinking, which is of crucial importance for psychiatry and for psychotherapy. So in this respect, phenomenology is probably one of the few sources of this, let's say, protective intellectual infrastructure for a clinician.
Really, thank you. Today we have at this Congress many different mental health professionals who has different roles in the treatment of patients who are engaged at different levels of the treatment. So I would like you to give us some general suggestions for our mental health professionals in their daily operations.
It's the right question. Because it brings it to a sort of immediate level of experience also for the practitioner. But it's also very difficult to make concrete examples. But one aspect that I can say is that, through this approach, you maintain a certain openness to being bewildered by what is going to happen in the clinical situation. And you try to bracket a lot of prejudices that might, deform what you understand from the patient or from the family, and sort of iterate this kind of misunderstanding. Whereas through this sort of, I would call it clinical phenomenological approach, but the key point is more a kind of Socratic-like approach in which you try to maintain a very extreme open-mindedness and you try to get rid of your own prejudices. So you do not override what the person says with your psychodynamic, systemic, or cognitive behavioral frameworks, but you simply stay at a sort of, experiential pairing with the person in front of you or with the family or with the group of people that are sort of asking for help. Because an important thing is that it's not a sort of dyadic or monadic operation. You can apply this approach at a group level therapy as well. And you can apply it even in the sort of equipe work among specialists or, with nurses, doctors, psychologists, rehabilitation technicians, and all the figures that have a sort of broad involvement in mental health.
Professor Raballo, can we call it open curiosity in intersubjectivity?
Yes, I would say that this is a facet of the phenomenological approach.
Thank you. Thank you very much. Professor Fuchs?
I like that very much. Open curiosity into intersubjectivity is the attitude that we should foster, and what I would like to emphasize is that curiosity in what happens in between us, so to speak. So phenomenology is particularly interested not going inside the patient somehow, going behind his experience, going behind his words, but staying with the experience, staying with the words of the patient, and even staying with what happens in between us at the moment of the interaction. So being mindful, so to speak, for precisely what is going on at the level of intercorporeality, at the level of embodied presence, of expression and impression, of the atmosphere that can be felt in between us. And phenomenology would be a support for maintaining an attitude of awareness, of mindfulness to the presence. And there is so much richness in the presence. There's so much to be gained from being present. And what can be gained above all is, of course, the therapeutic relationship that already develops in this diagnostic stance of being aware, of being present, of being with the patient, because that is already a relational situation that helps going on with therapy afterwards. So phenomenological diagnostics would not be the classical psychopathology of looking at the patient from a distant observer position and marking certain symptoms and checking what can be wrong and what is deluded and so on. But phenomenology would lead to a certain openness for the situation of the patient and already establishing a relationship that helps to go on with therapy in general and psychotherapy in particular.
Thank you for your presence and the themes you discussed with us. We will see later Professor Fuchs live here with us. So instead, we have to thank again Professor Raballo and hope to see you again in the future and to have a cooperation with you in the future. So really thank you to both of you.
Thank you very much. It was a pleasure on my side as well.
It was a pleasure. Thank you. You're welcome. And looking forward to next steps.